Hello, ladies and gentlemen. Welcome here to my channel once again. My name is Divine, an advocate for a pharmacist with a difference. Today, I have a short a topic that I want to share with you. I mean, this is a common topic that I want to share with you. But before I go to today's session, I'd like to wish you guys a happy festive season, happy holidays, and I wish you, of course, a prosperous 2022 coming soon, and I'll see you into that year. You know what I'm saying? Yes. So basically, today I'm gonna talk to you about tuberculosis. So this in ideally I'm gonna be focusing more on the management, treatment of TB itself. So in this context, what I'm gonna be talking about today in this session is simply the drug susceptible tuberculosis. So I'm gonna write so you follow through this. What I'm gonna talk about is simply drug susceptible TB. Okay, so when you talk about drug stable tuberculosis, we're talking about the TB that is actually respond to the first line drugs or group 1 drugs. You know that TB medication are classified in various groups, 1 up to 6, one group 1, group 2. So when you talk about group 1, basically this is the most effective and fast rising medication that are coming in this category, group 1. So we talk about drug susceptible tuberculosis. We're referring to the TB or mycobacterium tuberculosis, which can be treated by the drug belonging to group 1. So that's what we're talking about basically here. So since, as I earlier highlighted, that I'm going to be focusing more from the pharmaceutical care of the TB itself, let me simply, you can't talk about something without defining what it is basically. So what is tuberculosis? Tuberculosis basically, in a simple definition, is a multi-systemic infection. Okay, this is a multi-systemic infection with a myriad presentation and manifestation, right? Which affects, of course, uh, uh, commonly the lungs. Okay, this is a lung infection. Of course, mostly about 80% of 85% plus of tuberculosis affects the pulmonary system, which is the lung itself. So an infection which is caused by mycobacterium tuberculosis. In short, as I earlier put things together, tuberculosis basically is a multi-systemic disease with a myriad manifestation and presentation, okay, which affects the pulmonary system. Okay, in this case, the lungs are mostly affected and caused by the mycobacterium tuberculosis, which is the species itself. So the mycobacterium species, of course, known as the MTB itself, um, it also belongs to a genus or a class, certain family of other species, which also cause different types of TB. In this category, examples that I want to highlight is that we have other family in this group of TB. We have other Africanum, like Africanum. Africanum is also another species. Okay, Africanum. We have got bovis, mycobacterium. Of these are other types of mycobacterium. Bovis. Okay, there are other type of mycobacterium species that are simply atypical pathogens. These type of atypical pathogens cause a different type of TB or atypical TB, like Mycobacterium avium complex, Mycobacterium abscentius. These are different species and they are, of course, treated by different types of medication. But today we're going to focusing at the Mycobacterium tuberculosis, okay, which of course sometimes referred to as hominis. This is what basically causes the disease that we're going to be talking about, tuberculosis basis. Okay, according to the estimate by WHO in 2009, somewhere there, they estimated by then that about 2 billion people 2 billion people have latent or have got tuberculosis. And this phrase of latence talk about that they have, of course, the mycobacterium that causes TB in the body, but they do not have the active disease. You see, there are many factors that can simply convey or rather cause or result to somebody having an active tuberculosis. And this centered basically due to the reduced immune system itself. When you can have a bacilli in latent phase, and at some point, as you grow older, your immune system becomes weaker. That's one way. The other thing is that if you are taking drugs that are known to reduce or suppress your immunity, for example, medication like glucocorticoids, these like prednisolone, dexamethasone, this long-term use of this medication can basically reduce your immune system. There are other, of course, many drugs that are immune modulators. For example, like tocilizumab. The other drugs that are being used, they can also lower immune system. So that can put somebody at risk of having the active form of tuberculosis from the latent phase. Okay, the other things, of course, apart from that, is that some even nutrition has been also linked. For example, deficiency vitamin D has really been linked to also manifestation of some of these infectious diseases, like especially tuberculosis itself. And of course, don't forgetting the common HIV, which of course, HIV, if you're not on treatment, basically your CD4 cells going to be destroyed, because HIV virus targets CD4 positive cells, and these cells of course includes the T lymphocytes, the macrophages, we're talking about the monocytes, the dendritic cells, and glial cells of the central nervous system. Now, TB affects or destroys, the HIV virus destroys all these cells. So, meaning that if you are not taking medication about very high viral load, means your CD4 cells going to be affected and begin to be reduced. As a result, you can be at risk of having the active TB itself. Okay, so just general about tuberculosis. Of course, you can get this organism being exposed from somebody who has TB, and in terms of infection itself, two important factors that play a role. Number one is that the concentration of the mycobacterium, of course, in the spit or saliva, or in something or rather aerosol, on an aerosol or aerosolized spit. So that also determines the person or the next person from getting this TB from you. Okay, the other thing, of course, also is contact time. That's why it's another very important part. That's why we recommend that in TB wards that their windows must be kept open, so that at least we don't simply increase the concentration, of course, of the bacilli in the room, that so other people come to visit may easily get TB. So that's a very important thing to take note, of course. So when it comes to symptoms of TB themselves, there are generally four important things that are referred to as constitutional symptoms or signs of TB. And these things, of course, are very important. Number one is what we call night sweats, so sweating at night. Number two, of course, is a cough. Nowadays, of course, can be productive or even just a dry, of course, which later on progresses to productivity. Of course, that's number two. And of course, also is anorexia / weight loss. Of course, when you have got reduced appetite, next time happens is that eating, and if you're not eating, you lose weight basically. So that's why that's another thing. And the other thing, of course, is what you understand is that also fevers. So fevers is another important thing that you have to know with regard to constitution. So number one, of course, anorexia or weight loss, productive cough, night sweats, and fevers. These are constitutional signs or core signs that you have to see with regard to TB. Usually, of course, 2 weeks and above, these signs present 2 weeks and above. And of course, usually sometimes may not be getting better with other use of normal drugs. Okay, this is simply having this. So currently in areas where TB is a very high or epidemic, for example, in those areas, we recommend that if somebody just have a cough that is productive, that is lasting for more than 2 weeks, preferably you have to go for TB screening. That's a recommendation that you have to do as under fevers present. So having that simply generate briefly about tuberculosis and what basically it is. So how do you manage? How is TB treated? So in this case, I'm talking about pharmaceutical management of tuberculosis. Okay, so that's what I want to focus on in this list of the presentation. Now, since we're talking about this guy known as the drug susceptible tuberculosis, okay, and this is known that it's caused by Mycobacterium tuberculosis, which is the cause of this thing, and this is a bacilli, which of course poorly stand for gram positive and gram negative, but we are standing for gram positive, okay? But basically it's a bacilli. It's an aerobic organism. It loves areas which are rich in oxygen. That's why the lungs are the most primary site for TB infection. Of course, TB can go to other sites, for example, in the spine where you've got excess oxygen as well, in the brain, you've got enough oxygen in the brain as well. Those other sites can be affected. So how do you treat drug susceptible tuberculosis? So they are basically, it's treated in two phases. There are two phases that we treat TB, okay? So very important, there are two phases. The first step is called the inductive phase, okay? This is inductive phase. And this phase, of course, is simply initial, or can call it also in the initial phase. In the initial phase, we are talking about drug susceptible tuberculosis. We use 4 drugs that are recommended. Of course, the rule of TB treatment, before I go further, let me highlight that the goals of therapy and the rule. The rule of TB therapy basically is that never use monotherapy. So the studies, of course, recommend that it must be two drugs, at least two drugs, to which the mycobacterium is susceptible to. So that's the rule of TB therapy. All right, but in our context, that the WHO recommends the use of 4 drugs in the initial phase. Of course, at least 2 drugs, right? That's the general. Sometimes even 3 drugs are okay, especially in the area where resistance is not a problem. You can actually use simple. You can remove rifampin. You can remove your ethambutol, not rifampin, but ethambutol, which of course act as a resistant barrier. Now, the first initial phase you use, of course, is about 2 weeks. So this is at least 2 weeks. I mean, at least 2 months. So the initial phase is 2 months, at least 2 months. That's the initial phase. All right. So in this case, using the 4 drugs, we're using, of course, isoniazid. I'm going to use as INH. The other one, of course, is RIF, which is rifampicin. The other drug that we use, of course, in this category is PZ, which is pyrazinamide, and we have got the ethambutol. So this 4 drugs are used in the first 2 months, which of course is initial phase or intensive phase. Okay, at least 2 months, of course. Then some patients can get longer than that, depending on what time it took for them to obtain a negative or a sputum, of course. So the ideal of this first induction phase is simply to rapidly obtain a negative sputum, or rather sterilize, okay, so that the patient is, of course, no longer become infectious, and in terms of even self-infection, where they progress to severe disease, systemically, even TB sepsis themselves. So this is simply to rapidly reduce the mycobacterium species themselves. So these drugs are very important medication that are used, of course, in the first 4 months. And now we have this combination that comes as 4FDC, which 4FDC. Okay, this simply stands for 4 drugs, fixed dose combination, where that these medication are simply enclosed in 1 tablet, so they are all in 1 tablet. This is simply to reduce to the pill burden and simply improve drug compliance to the patient. Okay, so these drugs are used in the first 2 months. After 2 months, of course, you with a successive treatment where you have to do a culture itself, culture to determine that there is not any growth of the bacilli. Then you can now de-escalate, where you remove, of course, the 2 drugs. So these drugs, of course, will be removed. The remaining 6 months, of course, if it's no other complication, you treat for 6 months. But if TB meningitis and also other type of TB, spine or bone TB, have gone up to 12 months of therapy. But if it's just this simple TB, you treat for 6 months at least. So we're gonna drop these 2 drugs, and the remaining 6 months, remaining 4 months, of course, you're gonna be using, of course, rifampicin, which is RIF, and also isoniazid. This is, of course, the latter part of therapy, because these are the core drugs. So we know what basically TB is treated itself and what drugs are used. And I've highlighted the fact that the 4 drugs are used, of course, in initial phase, and later on you go down to that first. Let me talk about the dosages of this medication, and then I'll highlight a few things regarding these drugs, because dosing is very important as a pharmacist to make sure that the patient is getting the appropriate dose of the drug of this TB medication. And of course, you have to know what you're monitoring for as a pharmacist, because patients will come for refill, and there's things that you have to ask patients some questions and a few things that you do. Okay, so let's start with isoniazid. So let me highlight that isoniazid and rifampicin, these are core drugs. These are backbone drugs, because this medication, they are what, like say that one of them, for example, isoniazid is a drug that is got excellent tissue penetration. This is the drug which has got the most tissue penetration, is this guy here. Okay, isoniazid. Okay, rifampicin, of course, is good, of course, and also is effective in almost all population of mycobacterium. So both intracellularly and of course, and also extracellular concentration of the bacilli themselves and other calcareous tissue. So rifampicin is able to penetrate all those tissues as well, but its CNS penetration is not superior to isoniazid. Isoniazid is superior in regards to CNS penetration. All right. So And again, rifampicin, apart from that other thing, but rifampicin, special thing about this drug is that it has got the drug that's got fast sterilizing effect. This is the drug which has got a fast sterilizing effect among the 4-DC drug that we use, of course, the 4 drugs that are used in the first, or rather in the drugs for tuberculosis. Let's highlight them. Now, the dose of isoniazid basically ranges from 5 to 10 milligrams per kg per day. This is, of course, the dose. Basically, for adults, you stick, of course, to your 5 milligrams per kg body weight and not exceeding 300 milligrams in 24 hours. We'd like to comment that, of course, there's what we call high dose isoniazid, which may be up to 50 milligrams, but that high dose 50 milligrams per kg body weight, ideally it's like to be used when you're giving it 3 times a week. Okay, usually not exceeding 900 milligrams 1 to 3 times a week. That's administration. Can be used, of course, of isoniazid. That's high dose isoniazid. Okay, but therapeutic for active TB, basically for adults, usually 5 milligrams, and the maximum being 300 milligrams in a day is sufficient to treat that tuberculosis. That's isoniazid. And rifampicin dose basically for this one is 10 milligrams per kg body weight and per day. So this, of course, remember that TB drugs are weight-based dosing medication, so that's why you take weight more serious in this aspect. So these ones, of course, you're not exceeding, don't exceed what we call 600 milligrams per 24 hours. So that's the dose of, don't exceed 600 milligrams. So 600 milligrams is simply a maximum 24-hour dose of rifampicin, all right, with regard to this kind of TB. And then pyrazinamide dose for PZ active tuberculosis, the dose basically ranges from 20 to 40 milligrams per kg body weight and per day, and do not exceed 2 grams in 24 hours. So this is, of course, our maximum dose with regard to pyrazinamide. And the last, ladies and gentlemen, is simply ethambutol. Ethambutol dose for ethambutol is simply 15 milligrams. So here's the thing: there are 2 aspect dosing part. In patients who have never been exposed to what you call ethambutol, right? Those are new patients. In short, the dose, of course, is 15 milligrams per kg body weight per day, all right? But those that have once been exposed to the first 60 days, that is 2 months, you're starting, of course, at a higher dose, which, of course, is simply 25 milligrams per kg body weight per day. And then after 60 days, you de-escalate or decrease the dose to 15 milligrams per kg body weight. So that's the dosing aspect of this tuberculosis. Now I've highlighted the dosing aspect, so you know how these medications are dosed and how important they are regard to TB, which is, of course, first initial and then later on and the other things. So meaning that people, when they come for refill, you have to make sure that you weigh them and see if maybe they might need to do that. So to do either dose increase or reduce based on the weight of the patient themselves. Of course, we expect that they might gain weight, you know, if they're eating well, because as they're on drugs, there's a reduced concentration of the mycobacterium in the blood, in the plasma, and also just pulmonary infection is reduced, and the reduced, of course, circulating chemokines, which, of course, affects or alter appetite. The fact that the appetite will be improved over time, and then they will begin to eat well, so they'll gain. So that's why you must be checking their weight. Now, let's now highlight further now on medication. Talk about these medication now, what we need to know about them. Now, before I talk about that point, we have what we call in our setting, in Zambia, for instance, we have what we call a 4-drug fixed dose combination, which is known as the 4FDC. So 4FDC basically is a 4 drugs fixed combination, and this fixed dose is isoniazid in it. There's isoniazid, which is INH. Okay, we have got rifampicin, which is like this RIF. We've got PZ, and as well as also ethambutol. Now, this, the one we have, of course, in our setting, for example, this is Zambia that I've seen, is that there's what you call compositional strength. What is the strength of the individual drugs in this 4FDC? And the first for isoniazid in 4FDC comes in at 75 milligrams. This is not a dose. This is the strength composition of isoniazid in the fixed dose combination. Okay, so the isoniazid comes in at 75 milligrams, and the rifampicin is 150 milligrams. Okay, the pyrazinamide here, of course, PZ here comes in as 400 milligrams. Okay, and of course ethambutol comes as 275 milligrams. So this is the composition strength of the drug itself. So here's what basically it comes. Now, in short, for example, let's say assume we've got a patient who weighs 60 kgs, and this patient, of course, weighs 60 kgs, and we want to give the fixed dose combination, which is a 4-drug combination. So we want